Welcome to Spine Academy. In this video, we're going to discuss the posterior cervical exposure plane. We'll talk about the corridor itself and some of the common indications for surgery from a posterior approach. This is an excerpt from a broader course in which we provide a high-level overview of the different types of cervical spine surgery. If you're interested in seeing the full course, we've left a link in the description. Posterior cervical approaches are approaches to the spine from the back. If you look at an image like this, where you can see this person is obviously facing in that direction with the mid-sagittal section through the spine. Here you can see here's the spine, here's the spinal cord. This would be the front of the neck here, and then this is the back of the neck. So posterior approaches are approaches in which we come at the spine from the back here. If you were to look at a slice of the spine like this would be an axial section through the spine. And here you can see the spine itself, you can see the spinal cord and the nerves, the intervertebral disc here, here's the joints in the back, or the facets as we call them, lamina, spinous process. So you can see the spine, you can see the spinal cord and the nerves, and then you can see some of the structures that are around it. In the back, it's principally muscle. So you can see you have all this paravertebral musculature, or muscle on the side of the spine, that's on both sides. And these are paired. There's some on the right and some on the left here. In addition, you can see there's some structures in the front. For the posterior approach, these are approaches to the spine that start in the back. So that means you're coming at it from this direction. When you do that, you are generally exposing the spinous process and the lamina and some of these structures, and it gives you access to this area here. So that might look a little bit like this. You can see kind of the target area of interest is really the back of the spinal cord, so that's this portion here, the back of the spinal nerves on both sides. But you have access to the spinous process, the lamina, some of the joints out here, and the back of the nerves as well. So posterior approaches are approaches from the back or from the posterior aspect of the neck. They can target pathology that is behind or posterior to the spinal cord and the spinal nerves, and that is this area over here. Generally, when we do these procedures, we are able to come at the spine from a posterior approach and address pathology in the back. So here you can see there's some ligament thickening here. That ligamentum flavum is causing pressure on the spinal cord, and from a posterior approach, you'd be able to remove that and decompress the spinal cord. So we'll talk a little bit about how that is done. Again, looking at this image where you can see here's the midline, the spinous process, and the muscles on both sides. In general, when we do these procedures, we make an incision that is up and down in the middle of the spine. So that is like if you feel the back of your neck, you can kind of feel those little ridges. That is the midline, and those are the spinous processes. So we'll make an incision that goes up and down. When we do that, we will expose the spinous process, and then usually we're not removing a lot of muscle, but just detaching the muscle from its insertions along the bone here. So we would detach the muscles all the way out and expose usually the lateral mass all the way. So they're taking the muscle off of the spinous process, off of the lamina, off the lateral masses, and that's generally done on both sides. So this is a symmetric procedure. It's a midline approach, allows you to decompress fairly symmetrically. You don't always have to, depending on the pathology, but if you look at what you have access to, it's the stuff that's right behind the spinal cord and right behind each of the nerves, the right and the left. So that is how the exposure itself is done. It would allow you to expose pathology that is behind the spinal cord. So again, this is what an axial slice might look like for this pathology through one of those levels. And you can see when you go in from the back and expose this, you could remove the lamina with something called a laminectomy, remove the ligamentum flavum, but really get at the pathology that's causing pressure on the spinal cord and the spinal nerves. And that's because you're approaching it from the same side as where that pathology is. Now, in addition, besides having ligament thickening over here, there's some situations like this where you could imagine a sagittal slice. You can see that there's fairly significant disc degeneration here and some bone spurs formed there. If you took an axial slice route, you can see some of these bone spurs causing pressure on this spinal nerve, and it's causing pressure both from the back with this so-called facet hypertrophy and some pressure from the front of something called uncovertebral hypertrophy. When you come at the spine from the back through posterior approaches, you basically can remove the stuff that is behind the nerves. You can't really get to this stuff that's in front of the nerves because you would have to go through the nerve for it, and we don't generally do that. you couldn't get to any stuff. If there was disc material up here, you couldn't really get to that from the back. You can really unroof the spinal cord. And if you were to remove this and allow the spinal cord to drift back, that may be sufficient in letting it just have some more room, even if it's being pushed from the front. But in general, from posterior approaches, you can access pathology that is behind the spinal nerves and the spinal cord, so you could access this part of it. One thing you could not do is you could not, coming at it from the back, get to these discs. And as a consequence, you can't really remove disc herniations that are kind of in the middle. You can get sometimes some far lateral ones, and we'll talk about a procedure how you can do that. You also can't restore disc height, right? You can't get into that disc, you can't distract it open. So posterior approaches are not great for restoring disc height, and as a consequence, they're not great for changing the alignment of the spine, really. So one very unique and powerful characteristic of posterior cervical approaches is that they're very good for taking the pressure off of the spinal cord. Now, if you look at an image like this, for example, you'll notice in this patient there's some degree of cervical degeneration. Here's the spinal cord here and the spinal canal. And you can see there's not a lot of degeneration, but there is a fair amount of compression on the spinal cord. And this brings me to a very interesting clinical condition that I'd like to talk about called congenital stenosis. So just like all of us are born with certain size ears and nose and voice and height, those are all characteristics that are inherited from our parents. And those congenital characteristics don't just end with physical features like that. The spinal canal and the size of the spinal canal is also something that we inherit. Some people are born with very small spinal canals, some people are born with big spinal canals. And you can imagine a situation where the spinal canal can be just a little bit bigger than the spinal cord. And we call that situation congenital stenosis. So congenital stenosis is really an inherited condition. It's a condition that you get from your parents, and often it runs in families, in which the spinal canal is structurally small relative to the spinal cord. So even mild degrees of degeneration, like you might see over here, can cause significant spinal cord or spinal nerve compression. That condition is called congenital stenosis, and it is a unique situation that we often will approach, if we have to from a surgical standpoint, from a posterior approach. And that's part of the reason I wanted to bring it up in this setting. So posterior cervical approaches are a very powerful set of different surgical procedures, but I'd summarize the characteristics of posterior approaches as follows. First of all, posterior approaches are great for addressing pathology that is in the back of the spinal cord and spinal nerves. So everything that is behind it, or what we call dorsal or posterior to the spinal cord and spinal nerves, that is what is accessible from the posterior cervical surgeries. These are procedures that are excellent for many levels. They're good because you can expose all the way from the top of the spine to the bottom of the spine. You can do as many levels as you want without much incremental consequence. Doing 4 levels versus 6 levels versus 8 levels is all not necessarily linearly proportionally more difficult. You can do as many levels as you need, and you can get to extreme levels. So you can get to the upper cervical spine, or down to the cervical thoracic junction, or other places that might not even be accessible from other approaches. Because you can take the pressure off of the spinal cord from the back, and we'll talk about some techniques for doing that, you are unroofing the spinal cord. And there are many situations where the spinal cord is under pressure at many levels, where unroofing it at many levels is better achieved from the back. And that allows the spinal cord to kind of drift back into the space that you've created, and kind of indirectly decompresses the spinal cord by creating room for it to migrate into. You cannot really correct alignment from the posterior approach. You can get what alignment people have, you can even lock them in that position, but if people need alignment correction, usually you have to do something from the front to facilitate that. When we do surgeries from the back, there's usually more neck pain afterwards, and that is a byproduct of all the muscle dissection. Even if you're not cutting out muscle, just moving the muscle from side to side can cause a fair amount of neck pain and muscle pain and sometimes spasms and stuff. Usually that is short-lived, that's right after surgery, and it dissipates over time, but sometimes people can have ongoing neck pain related to the surgery itself. What I have found anecdotally is that patients that are older tend to tolerate surgeries from the back better than people that are younger. They also tend to tolerate surgeries sometimes better from the back than they do from the front. It's just, that is very anecdotal. I wouldn't say that that's gospel by any means. There are a variety of considerations that we use as surgeons in trying to figure out what the right surgical technique or even surgical approach might be for patients, and age is one consideration. Having said that, the posterior cervical approaches have very unique characteristics that I wanted to outline. We'll talk more in other videos about the specific procedures that constitute the posterior cervical approaches, but understanding the role of it is very important as a spine surgeon. Thank you for watching this video. I hope you found it informative. If you've enjoyed it, please like and subscribe. If you have any questions, comments, or ideas for future content, we'd welcome them in the comment section below.